So the goal is to discuss the classification of spontaneous preterm birth, review some of the pathophysiology pathways that lead to preterm birth, and then talk about how understanding those pathways can impact how we discuss treatment and prevention of the next preterm birth. So to start, let's do a couple of cases. So this is case one. This is a patient who's coming to us for her second pregnancy. In her prior pregnancy, she had a normal anatomy and cervical length, and then a week and a half later presented with spotting and cramping, was found to be 1 centimeter dilated, and subsequently went into spontaneous labor and delivered. The placental pathology was notable for a comment saying evidence of placental abruption. So how many of you guys, and you can do a show of hands, I can't see everyone, would call that a spontaneous preterm birth? Just Jason? Okay. Next case, this is case two. So same thing. So G2P0, she similarly, in the prior pregnancy had a normal anatomy and cervical length, and then a week and a half later presented with spotting. She was dilated on exam and then subsequently went into labor. Her placental pathology was notable for acute choreo. So how many would call case two a spontaneous preterm birth? Okay, so case one was a little mixed. Case two, everyone feels like, okay, that's a spontaneous preterm birth. Now let's look at case three. So this is G2P1, so viable delivery. Last pregnancy, again, uncomplicated, normal anatomy and cervical length, and then at 28 weeks presented with gross vaginal bleeding, severe pain. She was not dilated and quickly underwent a stat cesarean for non-reassuring tracing. There was gross abruption noted at time of delivery. And how many would call that a spontaneous preterm birth?
I'm going to put my hand up that I would, but I recognize I probably haven't in the past when I've read charts similar to that.
Yeah, it's okay. So similarly mixed pictures. I mean, I'm glad to see that people have mixed feelings about it. That's really the entire motivation for this talk. So, given that mixed picture, so for case one, where this is the patient who was 1 centimeter dilated, came in with cramping and bleeding and had abruption noted at pathology, although not clinically noted. How many would recommend a cerclage for that patient? Like history indicated cerclage. Okay, what about progestin therapy? Okay, aspirin. Okay, and then cervical length screening. Great. Okay, case two, so mixed bag there. Case two, same thing. How many would offer a history indicated cerclage? Okay, most people. What about progestin therapy? Most people. Aspirin. Yep. And then cervical length screening, presumably they didn't get a cerclage. Yep. Okay. And then last case. So this was the 28-week, basically gross clinical abruption stats action. How many would offer that patient a history indicated cerclage? Nobody. Progestin therapy? Nobody. Aspirin? Yes. Cervical length screening? Yes. We're happy to do ultrasounds. Okay, so let's talk about preterm birth. And the reason I'm talking about what is a preterm birth is because that kind of affects how you approach the management of it. So if you think about a disease, that's a specific process that leads to a certain collection of symptoms and then a final an outcome. Whereas a syndrome, you have a group of symptoms that go together, but we don't have a clear cause of what exactly is leading to those group of symptoms, which then goes on to isn't necessarily a clear treatment path to treat that or prevent that symptom. So when you think about spontaneous preterm birth, if we try to classify it as a disease, we know that there's pathologic change that happens, right? We know there's contractions preterm, there's cervical dilation, there might be rupture of membranes, and that collection of changes ultimately leads to a preterm birth. That can be preceded, although not always, by some signs and symptoms like cervical shortening, bleeding, contractions. So these are things that can present that don't always lead to a preterm birth, but can be a sign of preceding the pathology, which is ultimately delivering early. And then the problem is we don't really have a specific biological cause that can lead to this. When you think about it as a syndrome, you can kind of expand and think about what, there's actually multiple pathways that could lead to this collection of findings that results in a preterm birth, which is dilation, rupture of membranes, and contractions that, if without intervention leads to a delivery less than 37 weeks. Those collection of symptoms, like we talked about, can be, but aren't always preceded by some earlier signs that may not always lead to a preterm delivery, but can be a harbinger for it. And there are a lot of different potential pathways that could lead to these collection of changes that lead to preterm birth. Infection, connective tissue integrity, thrombosis or vascular pathology, like specifically thinking placental pathology, inflammation, immune dysregulation, stress. So all of these are contributing and intersecting pathways that will lead to whatever activation of pathways that ultimately leads to dilation, cervical change, and delivery less than 37 weeks, absent any intervention. So there's also a lot of data supporting that preterm birth is a syndrome rather than a specific disease process. So when we have these what's called multi-omic studies, that means you're looking at changes in metabolome, you're looking at changes in genome, you're looking at changes in gene expression. Those have identified multiple different systems that are identified to be different in cases of spontaneous preterm labor versus normal term delivery. So there isn't just one pathway. There are multiple pathways and multiple systems involved. So when we talk about preterm birth as a syndrome, I'm just going to go through some of the pathways and the supporting, how that pathway leads to preterm birth. So I think the one we think about most commonly and we perhaps understand the best is connective tissue integrity. So cervical stroma, that's our cervical connective tissue, includes fibroblasts and smooth muscle cells. These form an extracellular matrix, and the mechanical strength of the cervix depends on that collagen network and the extracellular matrix. Cervical remodeling is a term that we use to describe the changes in that stroma, in that extracellular matrix, that lead to a breakdown and degradation of that matrix, which ultimately leads to weakening of the cervical, tensile strength. And, that's what leads to shortening, dilation, and delivery. Remodeling includes not just a change in that structural integrity of the matrix, it's also associated with a change in immune cells. So when you have degradation of the extracellular matrix, there's also been associated with increase in immune cells and macrophages, and it's thought that those contribute to that breakdown. And so, it is a chicken and egg situation. It's not that one precedes the other or the other precedes one. We don't know, but whether you have a degradation of the matrix, which leads to, subclinical infection, which leads to an increase in immune cells, or you have an increase in immune cells due to an infection, which then leads to a breakdown of the matrix. So,
I would also add to that macrophages can just be involved in tissue remodeling without any sort of infectious
cause, right? Yeah. And so, which goes into sort of immune regulation, which, there's inflammation and infection, and there's also just immune regulation or dysregulation. So these are all, interrelated pathways. It's not just 1, 2, 3. And so that makes understanding and preventing preterm birth more complicated. Data that suggests that preterm birth is related to connective tissue integrity. There was a study that found that early spontaneous preterm birth was associated with an enrichment of expression of genes related to extracellular matrix degradation. I just picked some recent publications relating to this. Of course, there's a lot of data on this subject. There was a proteomics analysis of cervicovaginal fluid, looking at preterm births versus controls, and found differences in levels of various proteins in the extracellular matrix. So again, just going along the data to support the fact that this pathway related to connective tissue integrity is involved in the ultimate progression to preterm birth, although it doesn't really tell us, again, the order of events of what's happening. I'm going on to infection. Another common topic, 25% of spontaneous preterm birth is associated with an intraamniotic infection, whether clinical or subclinical, meaning it was diagnosed by, triple I or, amniocentesis with evidence of subclinical infection. These infections, as we know, are polymicrobial and associated with organisms in the lower genital tract. When you talk about immune dysregulation, I think this is very interesting and plays closely with infection, inflammation, and connective tissue integrity. So pregnancy is an immune quiescent state. It's not immune suppressive, so your immune system isn't suppressed, but there is a relative suppression in cell-mediated immunity. So you have a relative increase in T regulatory cells to promote this sort of quiescent or tolerant state of pregnancy. And an imbalance in that Th1 versus Th2 cells and downstream cells and pathways is related to, has been identified in spontaneous preterm birth compared to controls. And that's, again, I just picked one recent study. There's a lot of different studies that show this differential expression of pro-inflammatory versus immune quiescent cell expression, gene expression, and other inflammatory markers that arise from those cells. Toll-like receptors have also been fairly extensively studied in the pathophysiology of preterm birth. The reason for this is that TLR signaling specifically has been associated with cervical remodeling in preterm labor. One of the ones that's most well evaluated or that seems to be most strongly related to this is TLR4. And this is supported on the hypothesis that this is involved is supported on multiple levels. So one, TLR4 is expressed sort of across the gamut. It's on cervical tissue, it's on the fetal membrane, it's in the uterine, decidua, and the myometrium. And there are a lot of different ligands that can activate TLR4 ligands that activate these pathways that lead to changes in amniotic membrane integrity, so PPROM, changes in cervical remodeling, so cervical shortening and dilation, and uterine contractility. Sorry, 1 second. Is this someone that can wait? Or?
Well, we've never seen her. She's very happy. She's seen it says she's a week today she has her period. Somewhat.
Okay, she's got to wait like 20 minutes.
Okay.
Thanks. Sorry about that. Is my screen still sharing or did I cancel it?
You can see it.
So next is looking at thrombosis and vascular disease. And something is wrong that I can't advance.
It's just not in full screen anymore. But
oh, let me see what. I'm just going to stop it and start it again because it's also not letting me advance my slides. Are you seeing it now?
Yeah.
yes. Yeah.
Okay. So looking at thrombosis and vascular disease, I really like to bring this up with preterm labor because this is something that we usually associate with preeclampsia and preterm preeclampsia when we're talking about placental vascular pathology. But it's important to realize that abnormal spiral artery form development is not just associated with preterm preeclampsia. It's also associated with spontaneous preterm labor. This was a study from some time ago now. This is from early 2000 But basically they looked at placental histopathology in normal term deliveries, preterm labor, and preeclampsia. And you can see that there is this stepwise increase in non-transformed spiral arteries. So again, so you don't have that nice, large area of blood flow. And so you get this relative placental hypoperfusion. And you can see that even you have, that's significantly greater in preterm preeclampsia, but it is also significantly greater in preterm labor. And so these are overlapping pathways. They're not necessarily completely distinct disease entities. And this vascular malperfusion and vascular placental pathology is also associated with spontaneous preterm birth. Along those lines, this was a study that was looking at platelet activation in preterm birth. And similarly, they were looking at platelet activation with or without intraamniotic infection. And so this, again, you have a normal term delivery, and then you have platelet activation, so preterm labor with or without infection, and then preterm labor, but with a term delivery. And again, you can see that preterm labor with or without an infection was associated with higher platelet activation as well. This was a study that we did here looking at platelet activation. So this is a specific genotypic variant that results in increased platelet activation. And that patients who were homozygous for that genotype had an overall increased rate of preterm birth. And that was true for both spontaneous and indicated. And this was indicated for preeclampsia or fetal growth restriction versus, of course, spontaneous. This genotype, this increased platelet activation, was also associated with an increased rate of placental, vascular pathology. So again, when you're looking at everything at the end, you can't necessarily determine a time-wise causative pathway, but these are all pointing towards the fact that these initial placental vascular insults lead to not just preterm preeclampsia and growth restriction, but also preterm labor. Stress is, a broad category. I think it's important to mention as we talk about the socioeconomic contributors to health, including racism. Again, multitude of studies. I just picked some more recent ones, but experiences of violence, racism, discrimination, socioeconomic disadvantage are all associated with significantly higher risk of spontaneous preterm birth, adjusting for other concrete things that you can measure like BMI and age and medical comorbidities. Related diagnoses of depression and anxiety are also associated with significantly increased risk for preterm birth. And so I use stress as a catch-all for these things, but these are just, just evidence of how things outside of the body that we don't necessarily equate with health have very concrete impacts on health. There's a lot of studies that have looked at the, physiologic basis for stress as a cause for, many medical complications, including preterm birth. Stress does affect multiple biologic systems, including HPA axis, including immune regulation or dysregulation and inflammatory pathways. And so there is a pathophysiologic process by which the impacts of stress on the body and on the various systems in body, affects systems that also are related to preterm labor and delivery. This was a really cool study from AJOG actually last year that I loved because I just thought it was just such an interesting finding and such a great direct examination of stress in preterm birth. So this was looking at oxidative stress, and they were looking at how changes in telomere length are associated with term or preterm delivery. Telomere length has been associated with, just death. So when you have shortened telomeres, that leads to cell death. It leads to, actual mortality. It's just actual mortality as well. As your cells die, you die. But this was specifically looking at telomere length in the embryo and, telomere length in gestational tissue and looking at the length of telomeres in the placenta, obviously following these deliveries, so term or preterm, you can see shortened telomere in preterm labor and delivery. So, it makes sense. You have cell death, you have oxidative stress, you have cell death, and that ultimately, when that's happening in your placenta and your membranes, you're going to have a reduced, functionality of that in preterm labor and delivery. So in short, we have all of these many studies in different fields showing that while you have this one outcome of a delivery less than 37 weeks, there are a lot of different pathways that play into that. And one of the problems, I think, with our attempts to treat and prevent preterm birth is we put everyone in one category. Say you did or did not have a spontaneous preterm birth. As you saw from the first 3 cases, we can't even decide what that is, much less than, assume that we're going to then be able to treat everyone with prior spontaneous preterm birth the same way, when in fact, there's maybe 10 different reasons and disease processes that could be leading to 10 different spontaneous preterm births. So let's talk about, a targeted approach. So if you think about targeting preterm birth, treating and preventing preterm birth as treating and preventing infection, connective tissue integrity, immune dysregulation, that really broadens how you look at each patient and potentially makes more effective the things that we do to prevent preterm birth. So, antibiotics for infection, that overall, big picture, we screen and treat for UTIs in pregnancy because we know that that can reduce the risk of preterm birth related to offending infection from asymptomatic bacteria. We know in PPROM that antibiotics increase latency. This was one of our PPROM studies looked at amniotic fluid markers with azithromycin and treatment, and we saw correlations between azithromycin treatment and inflammatory markers in the amniotic fluid for PPROM. Now let's think about progesterone and what systems that impacts. So progesterone acts via multiple different pathways. And here I'm talking about natural progesterone, not any of the biosynthetic. So bioidentical progesterone has been associated with impacting connective tissue integrity, immune regulation, and inflammation. And why do I bring this up? So progesterone in preterm birth prevention, it has not been shown to be effective in an unselected population, which goes along with the fact that there are specific disease processes activated in specific individuals, and those are the ones that would or would, will or will not benefit from progesterone therapy. It does reduce the risk of preterm birth in selected high-risk groups. Progesterone acts via a few different ways. So, most commonly we think about progesterone receptors. Progesterone receptors are found in the uterus, cervix, that impacts uterine contractility, impacts cervical modeling. There's also a lot of non-genomic interactions with progesterone. So progesterone also impacts inflammation and immune regulation. And it also acts via glucocorticoid receptor and corticotropin releasing hormone, and sort of that HPA axis, and how activation of that or suppression of that can reduce the risk of preterm birth. There's a lot of translational work showing showing how progesterone can reduce the risk of preterm birth. And I might have shown you guys these slides before. This was from a study in 2015. And you have, and this is looking at membrane integrity. So you have your control group, and then you have GM-CSF, that's an inflammatory activator. And so when you treat your membranes with GM-CSF, you have weakening of the membranes. This is baseline, so this is just your fetus or the membranes treated with progesterone. And then when you treat with GM-CSF on top of that, you can see that you still have that preservation of membrane integrity. So from here, you have a significant decrease in membrane integrity. And here, this is not statistically different. So that GM-CSF, that inflammatory pathway induced membrane weakening, is inhibited with progesterone therapy. It also has immune regulatory effects. So this was looking at a mouse model of preterm birth, a mouse model, a pregnant mouse model, and they looked at treatment with vaginal progesterone or not. And they found an increase in these T regulatory cells. So again, that's sort of your immune quiescent cell, and a decrease in macrophages associated with, in the setting of vaginal progesterone therapy. So that's playing into that immune regulation model. When you talk about, the other aspect of cervical stromal integrity, aside from progesterone, is of course short cervix. I just wanted to talk a little bit about history indicated cerclage. So ACOG does say that a history of one or more second trimester pregnancy in the setting of painless cervical dilation, absent labor or abruption, would be indication for a history indicated cerclage, or for offering a history indicated cerclage. FIGO, it has a slightly different definition for history indicated cerclage. It recommends history indicated cerclage for those with 3 or more prior preterm deliveries. The reason for this is that the basis of history indicated cerclage is largely based on one large randomized trial, I think from the early 90s. It's been some time now. But basically, they did a large randomized trial looking overall at history indicated cerclage and in a number of high-risk patients with, prior preterm birth. But they found, and overall that trial found benefit. And so that's the justification for history indicated cerclage. But in subgroup analyses, they found that the preterm birth rate was significantly lower. Early preterm birth rate was significantly lower in the patients who had 3 or more prior preterm births or second trimester losses. And that degree of benefit was not actually significant anymore in the patients with 2 or fewer prior second trimester losses or preterm births. And so I just wanted to bring that evidence just so you guys understand why there is a difference in recommendations and why some people don't offer or recommend a history indicated cerclage with just 1 prior loss or second trimester loss or early preterm birth. I personally do, but I want to show you the data behind that. And then finally, I want to talk a little bit about aspirin. And again, this goes into, I want to push you out beyond thinking about aspirin just for prevention of preeclampsia. So aspirin has been found to reduce the risk of not just preterm preeclampsia, but also spontaneous preterm birth in asymptomatic individuals. Aspirin works via COX-1 and COX-2 pathways. COX-1 leads, the COX-1 leads to prostaglandin development, which activates thromboxane A2, which leads to platelet activation and placental vasculopathies. That's sort of the hypothesis between the reason that aspirin, prevents preeclampsia and preterm birth, because you're reducing this placental vasculopathy. I will say there's, it also acts via COX-2, and this is something that Matt Hoffman and his colleagues are exploring. Exploring sort of how the aspirin and COX-2 inhibition pathway also leads to a reduction in preterm birth and preeclampsia. The theory there is the COX-2 pathway leads to generation of lipoxins, which are which lead to inflammation and oxidation, et cetera. And then if you inhibit that, then you're reducing those oxidative effects. So there's this antioxidative property. And that's something I think that we'll continue to learn more about, but it's not as well studied, that COX-2 pathway. It's important though, because the dose of aspirin needed to inhibit COX-1 versus COX-2 is different. And so that plays a lot into, what is the right dose for aspirin for prevention of preterm birth and preeclampsia. This was, I think, great. It shows that this was an analysis looking at patients who had, overall total population, high risk population and low risk population, and people who were treated with aspirin versus not. And you can see that in patients who were on aspirin, they had a reduced rate of hypoxia related placental changes. And so again, while we can never determine a timeline, but because the placenta is only examined at birth, but it's providing, the basis for that hypothesis that treatment with aspirin is reducing this placental pathology that ultimately leads to preterm birth and preeclampsia. This was looking at this is where I'm talking about lipoxins. And so inhibition of COX-2 leads to an increase in lipoxins, which have those anti-inflammatory effects. And so this was a secondary analysis of patients randomized to 60 milligrams of aspirin versus placebo. And there was higher level of lipoxins in those randomized to aspirin. This was looking at aspirin. This was a secondary analysis of a study in aspirin for prevention of recurrent pregnancy loss. When I thought it was interesting because basically they found that the pregnancy rate, they were looking at markers of inflammation, CRP, and they found that overall the study was negative, but they found that specifically there was a significant increase in clinical pregnancy. So aspirin was beneficial specifically in those with a high baseline inflammatory marker level. So again, does it work universally for everyone? No, but is it working in patients who are predisposed to this specific pathway activation? Yes, and so it goes towards, targeting therapy.
Dr. Boelig,
Yeah, go
you
ahead.
routinely test people for that, right?
No, nope, this was a secondary analysis
Yeah,
that is not
like,
routinely tested,
But
but
how would we implement that into like our
so
recommendation?
this wouldn't be, this isn't something that you could directly apply now, but it's something that, like that would push for a study of stratifying. So rather than, for example, trying an intervention on everyone with a history of recurrent pregnancy loss or everyone with a history of prior preterm birth, it would say, you know what, let's screen people for these elevated biomarkers. And those are the ones that we think are going to benefit. Maybe our overall trial was negative, but if we screen and target our therapy for the patients who we know are at risk for this specific pathway to preterm delivery, then we can target our therapy and we might see a benefit. So again, overall trial is negative, but if we target it to that specific at-risk group, then you can see a benefit. So this goes into, what are biomarkers that we could test for, in the first trimester to identify more narrowly who's going to benefit and potentially at what dose.
Okay, we're not ready to say like aspirin as a therapy for recurrent preterm loss or recurrent
Correct.
loss. Okay.
Yeah. Although I think anyone who's coming from an REI practice is
It's already on aspirin, but
yeah. There are, zooming out big picture. So going from, looking at translational studies and placental changes to clinical outcomes, antiplatelet agents and specifically aspirin was associated with significant reduction in spontaneous preterm delivery. This was a observational, so this was looking at randomized trials. This was an observational study, and it looked at patients with prior preterm birth and the association with aspirin and recurrent preterm birth, and found that specifically in patients with prior preterm birth, there was also a reduction in recurrent spontaneous preterm birth in those on aspirin. USPSTF, as we all know the guidelines, but I just want to highlight they have this very vague moderate risk factor of previous adverse pregnancy outcome, which is not well defined, but for me does include spontaneous preterm birth. So they, and that's to, again, broaden our view of spontaneous preterm birth and preeclampsia and fetal growth restriction as different things. They are overlapping pathways, and there are some pathways that lead to spontaneous preterm birth that also lead to preeclampsia and preterm and FGR. And I'd say that's highlighted also by studies on patients with prior preterm preeclampsia. Those patients are also at increased risk for spontaneous preterm birth and next pregnancy. So, I'm gonna this is looking at smoking cessation and also the impact of oxidative stress and reducing oxidative stress on placental pathology and preterm labor. I'm just going to go through this a little bit quickly because I need to see this patient, but basically this was looking at, so, a lot of negative trials on broad preventions of preterm birth and and again, it goes back to my central hypothesis, because spontaneous preterm birth isn't a single disease, and that's why one intervention isn't going to affect everyone with prior spontaneous preterm birth. So this was a large study looking at vitamin C and E supplementation for the prevention of hypertensive disorders of pregnancy. And they looked specifically on whether this was effective or what the benefits were in smokers versus non-smokers. So we know that smoking leads to oxidative stress. And that's, one of the potential pathophysiologies that leads to the observed much higher rate of spontaneous preterm birth, as well as growth restriction in patients and babies from maternal smokers. So when they looked specifically, and vitamin C and E are antioxidants. So when they looked specifically, again, overall, there was not a benefit. But when they looked specifically at smokers versus placebo, there was a reduced rate of preterm birth, less than 32 and less than 37 weeks in those who were smokers compared to not. So again, once you're doing secondary analyses, that's hypothesis generating. So it doesn't tell us for sure, but just points to the idea that one size, is not necessarily going to fit all. And the fact that one intervention was not effective in a large trial may not mean that that intervention isn't effective in preventing preterm birth, but that we need to identify who that intervention does actually prevent preterm birth in. So rather than thinking about prior spontaneous preterm birth as one single disease, I think we should think about what that individual's history was. And this is all early. So just thinking about, what do we hypothesize that pathway for preterm birth was? And then we can think about what intervention or maybe combination of interventions would be effective in that patient. So going back to, these cases and whether or not you think that it qualifies as spontaneous preterm birth or not, thinking about instead, what pathways do we think were implicated in it? So our first case, this was a patient at 21 weeks with cramping, spotting, and was found to be dilated. So, you can think for yourself that these are the things that I'm thinking about. Okay, well, there was, placental abruption was noted after the fact. We know that abruption can happen sort of at any time in labor. Was there inflammation related to that trigger that cervical shortening, contractions, bleeding, and abruption? And if you think like those are the pathways, okay, so what are the things that might help? So history indicated cerclage. This was second trimestral loss relating to preterm labor at 21 weeks. But when you think about history indicated cerclage and the ACOG definition, it specifically is about advanced cervical dilation and the asymptomatic cervical dilation. So in the absence of labor or abruption, which is not really what this patient came in with. So it's something that I would discuss and something you really need to kind of get into the weeds about, because again, we don't know the order of events. We just know what happened at the end. So was she dilated for a centimeter for 2 weeks before that? And then ultimately went, developed an infection, went into labor, whatever. So it's something that I would discuss, but it's not sort of the clear-cut picture. Progesterone, I would recommend. She spontaneously labored and delivered at 21 weeks. Aspirin, I would recommend. Again, there's for two reasons. One is there was noted abruption, so placental vascular pathology noted, and two is, like I said, I think spontaneous preterm labor. There's a lot of data supporting the benefit of aspirin in prevention of recurrent spontaneous preterm birth and spontaneous preterm birth overall. And then absent cerclage, I would recommend cervical length screening. So what about, keeping all that in mind? I want you guys to think about if this would change, how you would approach the second patient too. So this is someone who came in with spotting and was found to be dilated. And so again, would you, what were so not actively in labor at that time. So then what are you thinking about for this patient? Infection, she had choreo on placenta, connective tissue integrity, was spotting, but, we consider that asymptomatic, wasn't laboring, didn't come in with pain. So asymptomatic cervical dilation, 2 centimeters. So potentially inflammation pathways, potentially immune dysregulation, so a much broader spectrum of potential pathways that could be involved there. History indicated cerclage, I would say I would offer, this is someone with asymptomatic cervical dilation in the second trimester. Progesterone, again, I would recommend. Aspirin, I would offer, this isn't a case with a clear sort of vascular pathology related to it, but just given the data that's available, showing that aspirin does reduce a risk of a rate of spontaneous preterm birth in addition to preterm preeclampsia. I do discuss it with everyone who had a prior preterm birth. And then cervical length, of course, would recommend in the absence of a cerclage. And then I think the last one is probably the most difficult to tease out because abruption is defined in so many different ways. I like this case because it's not like a labor and abruption and what came first. Like this patient really came in with, she had a completely uncomplicated pregnancy. Like that day just had a severe episode of pain and bleeding and had an abruption. However, abruption is like that end product. So what was happening in that placenta that led to the abruption, right? And so for this patient, a history indicated cerclage would not be recommended at any reason. It was an over 28-week delivery. Progesterone, I would offer, understanding that it's not clear how much progesterone might affect the specific pathways that led to an abruption and led to her preterm delivery. Aspirin, I would definitely recommend. So that abnormal spiral artery development is associated with placental abruption. And so aspirin does prevent that specific disease process. And so I would strongly recommend aspirin for that patient. And I would do cervical length screening as well. Again, because we have a lack of understanding of these broad pathways that lead a placenta to abrupt, right? And we know that placental pathology is related to spontaneous labor and delivery. It's not just something that's restricted to indicated births or preeclampsia. And so I think until we, unfortunately, there's not a lot of answers here. I'm trying to push you to think about it differently so we can study it differently. But just thinking about, we need a better understanding of what these specific pathways are so we can actually target that disease process and not just kind of throw things in the wind and see what sticks.
So for these patients where you're offering aspirin, what dosing are you offering?
Just 81 milligrams.
I think singletons have not used more bigger doses. It's usually 100 or 200.
For aspirin?
No, I'm sorry, for vaginal progesterone.
Oh, yeah, progesterone, it's usually the 90 milligram gel or 100 or 200 milligrams progesterone. Any other questions or comments? Okay, thanks, guys. I'll leave you with this final thought that I just want to drive home and is my primary goal of this talk is to not think about spontaneous or indicated preterm birth. Those are very broad and artificial distinctions. There are multiple overlapping pathways to preterm birth. And so rather than thinking about was it spontaneous or indicated, like I want anyone who has a prior preterm birth, you need to go back into that history and explore what were all the factors related to that preterm birth. Was there labor? Was there a placental pathology? Is there a hypertensive disease? Is there smoking, et cetera? And then think about knowing all those pathways that you feel are affected or maybe involved in this patient, then thinking about what are the interventions that would specifically target that. Substance abuse treatment, smoking cessation, aspirin, progestin, cervical length screening. There are some, we have, of course, society guidelines and broad recommendations, and I'm not saying you shouldn't do those. I would continue to follow them, but I want you to go beyond them and really explore the history of every patient with a prior preterm birth and think about all of them as someone that you could do something potentially to prevent a recurrent preterm birth. And sometimes, it is just they had a prior myomectomy and a delivery at 36 weeks, and that's fine. But a lot of it is not that simple, and a lot of it is overlapping, and a person with prior preterm preeclampsia is at risk for a spontaneous preterm birth. A patient with a prior spontaneous preterm birth is at risk for preterm preeclampsia. Though they're not singular diseases, they're not singular pathways, and that patient is at risk for a broad array of things, and so I want to encourage us to think broadly. And ultimately, like for those of you going into research, I think this really goes into targeted therapy. And I presented a little bit of that data supporting that when you have these biomarkers, and when you look at a subset of people with a specific pathway marker assessed or a specific disease process, those are when you are finding benefit in therapies that broadly were found to be negative and maybe being dismissed. And that includes progesterone. I know there's a lot of debate on progesterone therapy. And as we talked about before, a lot of the difficulty is these studies were done in a very broad risk group of prior preterm birth. And a lot of questions are like, well, now, or, maybe that was too broad, and what is the specific subgroups that we can study to see who it is affecting the most. Thanks, everyone.
Thank you.
Thank you, Dr. Boelig.
Oh, and thanks. Amanda had posted in the chat on the 1993 trial, so you guys can review that yourself for history indicated cerclage.
I couldn't find the paper itself. I think
I know it's like this. It's like I think it's because it was done by RCOG, so it's like a British national, like their health services basically ran the trial and put out the results.
I requested it to the library a long time ago, but I couldn't find it.
Okay, guys, I got to run and see a patient, but thank you for your attention.
Thank you.
That just ties into the placental pathophysiology for a lot of obstetric conditions. This was from 2019. It's a like clinical opinion or expert series piece, so it's not a lot of original data, but now his computer's freezing. But basically it goes through how placental spiral artery remodeling causes a lot of different obstetrical conditions, including preterm preeclampsia, PPROM, preterm birth, etc. And so I really like this paper. I think it's a good summary of it. And again, I just want to get people to go beyond aspirin just for preterm preeclampsia, and placental vascular disease is only a risk factor for preeclampsia and growth restriction. So I'll send it out, but it's a great summary. Thanks, guys.
Thank you.